Welcome to A Real Affliction, BPD Culture and Stigma, a podcast devoted to exploring how we experience, treat, write about, advocate for, and conceptualize borderline personality disorder. My name is Cynthia Gralla. I'm a writer and teacher with a history of BPD. Edvard Munch's The Scream is one of the most recognizable paintings in the world. With his melting, agonized face clutched in his hands, the landscape undulating around him, the figure in the scream and his torment is familiar to those of us with BPD. In fact, some critics have theorized that Munch might have suffered from the disorder based on his biography. Munch is the favorite painter of Dr. Alexander Kriss, today's guest. I know this because he shares an anecdote about his patient's finely attuned sensibilities in his book, Borderline, the Biography of a Personality Disorder. He explains that one of his BPD patients guessed his admiration for Munch, even though he had never spoken it aloud. During the decades I spent in therapy, trying to change, I didn't wonder how patients may change their therapist in turn. But they might if the therapist is gifted with empathy and openness. Dr. Kriss is open to being changed, moved, and educated by his patients. This past April, he published Borderline, a narrative with parallel stories. In the first, he describes his encounter with a patient whom he calls Anna as she struggles to cope with her BPD. In the second, he anatomizes the history of not just the official BPD diagnosis, but also the broader conceptions of madness and femininity that have created an ever-shifting but ever-present space for people harrying the line between neurosis and psychosis from antiquity to the present day. Dr. Kriss's approach to therapy, which draws on psychoanalysis and other theories, is a heartening reminder that DBT is not the only option for people with BPD who want help. DBT has enabled many, many people to feel better and regain control of their lives, but there's no one therapy that works for everyone. In addition to his private practice, Dr. Kriss is a professor of psychology at Fordham University and director of the Fordham Community Mental Health Clinic. He's also the author of The Gaming Mind, a new psychology of video games and the power of play, and has written recent articles on attachment and pedagogy. He studied playwriting during his undergraduate years, which helps him to nimbly transition between Anna's story and the muddy and fascinating history of a conception of borderline experience over thousands of years. One of the criteria for BPD is a tendency to view people and ideas in black and white terms, sometimes called splitting. But in Borderline, Dr. Kriss calls out the splitting done by whole cultures. He writes, "These splits arise at a cultural level in order to promote simple stories that maintain the status quo over complex ones that challenge it. History itself cannot escape this compulsion. It is written by the victors, and thus the history of BPD is, perhaps above all else, the history of medical authority, of who decides what it means to be ill." I was hoping at the start that you could give people an overview of this biography of BPD that you give in the book. You kind of track the way medical authorities have viewed women and people who didn't really slot easily into these categories of healthy or psychotic. And I know it's a lot to summarize, but could you give people a picture of what that looks like over the centuries?
Yeah, I think that this approach to looking at BPD really started to dawn on me that there is this kind of uncanny parallel between a lot of individuals' experience of their disorder, so to speak, stemming from repeated experiences, especially early in life, in which they felt kind of invalidated or abused or cut off from their own history, and how that seemed to actually sync up to the history of the disorder itself. That this is, when you talk to people about BPD, it seems like it came out of nowhere in the 1980s, right? Or if you go a little bit further back, you could see some use of that similar language earlier in the 20th century. And then the history seems to stop. And in fact, there's all of these sort of severed threads that go way, way back that I think is not coincidental, right? That's part of how the disorder is treated is linked in some way to how the people who are labeled with the disorder have been treated. We go all the way back to basically the dawn of recorded history, right? We see this pattern of there's always been, as long as there's been any kind of notion of health or medicine or medical authority, people who don't fit the paradigm that the medical doctors, physicians are working in. And so then that poses a problem of how do you label people who are not just ill, but seem to be ill in a way that defies what people in that time, in that culture, believe illness to be. And it so often falls to people who are in ways that are not just due to illness, potentially nonconformist or second-class citizens of some kind. So the most enduring group is women, right? Sort of across culture, who often are put in a position simply due to their gender in which they are faced with a choice to either try to conform or be labeled as unwell because they do not conform. And so it's gone by different names, and what has been considered nonconformist or ill changes as the culture changes. But there's this idea, there's some through line there that is often been missing an appreciation of not just the symptoms themselves that the individual is experiencing, but how their condition is a product of how they are treated by family, right, on an individual level, and by culture and society on broader levels. We start in the book with ancient Greece and sort of this notion of hysterical illness, which was almost entirely attributed to women because it was attributed to anatomical dysfunctions in the womb.
The wandering uterus.
So-called wandering uterus. It's a ridiculous idea from contemporary medical standards, but it was also a very kind of savvy concept at the time because it was a way of explaining women's behavior that tied their behavior to the fact that they were women in this very kind of circular logical way. And then as time went on, the authority shifted from the sort of dawn of medicine in the Western world to religion and the church over medical and moral authority in Europe and elsewhere. And so then nonconformity became, and certain kinds of illness or problems that were hard to describe became not a physical problem, but a metaphysical problem: possession, sorcery, witchcraft. And so then that became a new kind of catch-all class of what do we do with people who are behaving in ways that we don't understand. And then continues on into the sort of industrialized world and the return of medicine and the so-called Enlightenment period and beyond, where hysteria, which had roots back in ancient Greece, reemerges and really starts to get codified as an illness that people having symptoms that cannot be explained, right? That don't behave the way illnesses are supposed to behave. People having sudden blindness that then they recover from, or limb paralysis, or all the symptoms of pregnancy, but they're not pregnant, right? Things that nobody could make any sense of in the body, and started to consider how that existed potentially in the mind. And then just skip ahead a bit, right? The idea is that the borderline label really emerges from a post-psychological, post-Freudian world where, as we came to understand the mind-body connection better, a lot of the symptoms that used to be very bodily, like I was saying, limb paralysis, blindness, instead started to be a kind of internal paralysis, right? An existential emptiness. And that ultimately got its own label, its own kind of catch-all of not quite this, not quite that. It's in the borderline, more or less, where we still are today.
The nice thing is that by the time this episode is released, I will have already released 2 episodes about hysteria, in which I interview a woman, an author named Nina Shope, and she wrote a book called Asylum. That's sort of a historical novel about Charcot and Augustine, his most famous patient. And we're both total nerds about hysteria. I have like a mini section of my bookshelf about hysteria, just because it comes up quite a bit in literary studies. And when I was getting my PhD, of course, we look at Freud and Lacan and those people. But hysteria was an interesting thing for me to look at, because I was also looking at dance and theater, and there's such a performance aspect to some of the things that were going on with Charcot's patients and kind of presenting them to audiences. So if anyone's interested to learn more about the hysteria part, they can look back at Nina's episodes from September and October. But I didn't know much about all the earlier things. And I just wanted to comment on one thing you said that I think is so important, that this category, this way of thinking, often affected the most disenfranchised or vulnerable people, like women. And another writer who's talked a little bit about this connection between mental illness and possession exorcism, demonization, is a First Nations writer named Alicia Elliott. She's a Tuscarora writer. So I think she's much better known in Canada than in the US right now. But she wrote an essay called A Mind Spread Out on the Ground, where she was talking about her own history with depression and her mother's history with schizoaffective disorder, and then tracing it back to colonization and also things like witchcraft accusations and trials, which you mentioned in the book, talking about how they demonized women who had symptoms or behaviors that fell outside the norm. And she also points out that colonialism did that too, to the indigenous peoples, saying, demonizing them. And her whole point is she's trying to figure out, why is there such an epidemic of mental illness among, indigenous communities, and at least in the US and Canada, and I imagine in a lot of places. So it's interesting. I hadn't really thought before reading that, and then your book about the connection with witchcraft, but it makes a lot of sense.
It also, what you're saying raises an important distinction between, the disenfranchised populations are not necessarily statistical minorities, right? Like
Right.
part of why you, I think, and others encounter like hysteria a lot if you read, Victorian era literature, is just incredibly common, right? This was not like a weird niche disorder. Slim number of people were diagnosed with. It was one of the most commonly diagnosed medical disorders of the era. It's not that just because people fell into this category that doctors didn't understand doesn't mean it was a small number of people. Many people who didn't fit in the boxes and got labeled with this thing that nevertheless made them feel and seem and appear to others to be something alien and different and marginalized.
Yeah. Well, it makes me think too of things like autoimmune disorders today, which, because I have lupus, and what I learned studying and doing research on that is that they're becoming more and more common, but most of them disproportionately affect women, and they are understudied. So it does seem like there are certain disorders and illnesses that, especially if they affect women, get less attention or, are misunderstood. So you have a background in psychoanalysis, and I know in your book you talk about treating a patient named Anna, who I think you would usually meet with her about 3 times a week. Is that correct?
Yeah, with a lot of my patients, it will scale back and forth depending on. So there can be extended periods of meeting, 3 or 4 times a week. But then also a lot of times with more intensive treatment, it sort of stabilizes at twice a week for a time. And then sometimes reducing to once or even once every other week. Yeah. So for that case that I write about a lot in the book, there was, I think 3 to 4 times a week was sort of a pretty regular pattern for at least a few years of the treatment.
A couple of my guests on the show so far have been really strong proponents of DBT and certainly dialectical behavior therapy. And certainly it's helped a lot of people. It does seem to be effective for many people with BPD. I always think that it's impossible for one treatment to work for everyone. So since you're doing something different, you're not doing one of the specialized treatments for BPD, like mentalization-based therapy or transference-focused therapy. So what does your therapy look like for BPD? Because I know you're now basically specializing in that in your private practice. Is that correct?
Yeah, it's a substantial part of my practice for years. And I don't sort of ascribe to any particular acronym, though I have been influenced by those things you mentioned, mentalization-based therapy, MBT, and transference-focused psychotherapy, TFP. I try to take a pluralistic approach that broadly is within sort of the tent of psychoanalytic or psychodynamic therapy, which are somewhat interchangeable terms. So, that really puts a focus on unconscious experience and helping people symbolize through language thoughts, feelings, patterns that maybe they've not been fully aware of previously. And it can be, I think, really powerful and effective for individuals who fall under the sort of the borderline diagnostic category, whose understanding of themselves and especially their history and the experiences they've been through can be in such a confused, jumbled, fractured state because so much of their experiences, especially early in life, were chaotic and confusing and did not easily yield to coherence or logic. So it's a more open-ended, less structured approach that can be anxiety provoking in some ways because it does not come with clear skills to teach and structure. It can also, I think, in that way, they'll be very empowering. It's really very led by the individual and sort of what is on their mind. And patients set the agenda, so to speak, and sort of having a prescribed course that they go through, which is more, especially the group component of DBT, is really structured like a class, which, as you said, some people find really helpful, and then other people find not helpful, and then sometimes find that they're told that the reason why it's not helpful is because they're doing it wrong, which is really the most problematic aspect of DBT's dominance in the mental health marketplace for BPD. Yeah. And I think a lot of clinicians who really push DBT or say if you have borderline issues, you must do DBT are well-intentioned, but potentially not. A lot of people who are being trained as psychologists and therapists in this country at this point get no exposure to psychoanalytic ideas. So they don't necessarily know what they're arguing against. They just know that the American Psychological Association sort of acknowledges DBT as an evidence-based practice for this condition. Be kind of bound by some of our jargon and our bureaucracy to feel like, well, if they say that this is the only thing that works, this must be the only thing that works, even though if you look a little more closely, that's not actually necessarily the case.
Yeah, I wonder if there was such an urgency to prove that BPD was treatable, because one of the stickiest slurs against it was, and really still is to some people, that it is untreatable. So when Marsha Linehan, she did test trials with DBT, she was getting good results. Maybe that's why it's been kind of put forward as the one and only. The rhetoric can almost seem like you have to do this. And I've never done the full DBT course. I'm at a point in my life where I would be willing to do it now. I think when I was in my most acute days with BPD in my late 20s, early 30s, it would have been really hard for me. And the group therapy intimidated me because I'd been hospitalized as a child for anorexia for long stretches, and I'd done group therapy, and I had really negative experiences. This is in the 1980s. It was not a very enlightened environment. So for me, that was really difficult to imagine. I think if I'd had someone in my area who did something more like you were doing with this kind of intensive psychotherapy, that would have been more comfortable for me. So that's one thing I wanted to get out there, that there are other models of treatment that can work depending on the person. And I agree with you about the lack of a coherent story people with BPD often have. And often there are memory gaps or definitely repressed things, because we often do have trauma. Since I'm bringing up trauma now, you talk a little bit near the end of the book about how the DSM, the Diagnostic and Statistical Manual of Mental Disorders, doesn't have any mention of trauma in its criteria for BPD. What do you think we lose by not viewing BPD as a trauma response, at least for many people?
Yeah, it's a great question. And I think as I was saying before about kind of what the overall approach of the book is on both the sort of individual level and this broader cultural historical level, I think it has negative effects on both levels. I think for individuals who are given this diagnosis of BPD, they are both potentially misled about the nature of what they're suffering from. They are made to feel excluded from a sort of elite club, that there are very few disorders that are officially recognized by the DSM that acknowledge that they come from, or at least are contributed to, by something that someone experienced. And so when you have diagnoses like post-traumatic stress disorder, PTSD, or complex post-traumatic stress disorder, which is not actually in the DSM, but does exist in the International Classification of Diseases, the ICD, those feel like, and patients have talked to me, like those labels feel like something bad happened to you. BPD can feel like you are bad. And the great irony is, CPTSD in particular as a disorder, which I talk about in the book, was derived from work with patients who were called BPD. Like they are not meaningfully distinguishable. It is an arbitrary thing that we put people in one box over another. And so then that, I think, speaks to then the broader kind of cultural effect, right? Is that the DSM and the way that we generally classify mental disorder gives this impression of these discrete boxes that is not actually how human experience works. It makes it easy for stigma to continue, right? And for people who are given a certain label to be cast just like hysterics, just like witches, as this other thing that's not like us and has no relation to the kinds of things that we normal people deal with. And it's harmful in sort of the obvious sense. And it's also just categorically untrue, right? That people who are labeled with BPD are not a different kind of person. They exist on different dimensions like we all do from each other and have had experiences oftentimes that many of us have not had and had to adapt to that in the way that people do, right? In predictable, understandable ways that put us all on a shared field.
Yeah. And you bring up as an example of this kind of something bad happened to you versus feeling like a bad person. You bring up the Johnny Depp and Amber Heard trial where she was claiming she had PTSD, and the psychologist that the Depp team paid to analyze her said, no, she has BPD and histrionic personality disorder. And it clearly was saying that PTSD is a no-fault diagnosis.
Right.
But BPD, that means she's toxic. I mean, I think it was appalling to a lot of people, but it kind of proves that goes on. As an extension of this, in your book, at one point, you described meeting another therapist at a party, and you mentioned that your specialization was working with BPD patients, and she said something like, oh, fun, implying that it was not at all. And I'm wondering, have you had more positive reactions from your colleagues?
There's definitely a mix. I mean, I do think, I talk a lot in the book about the sort of notion of splitting and how human beings have this tendency to create binaries, right? But
Absolutely.
that's long been considered a feature of sort of the borderline position, but it's also just a general human position and can also exist on cultural levels, right? Where we sort of decide that some people are good and some people are bad. I do find that there is some kind of a split that exists between clinicians who work with people wwho carry labels like BPD and clinicians who do. And those who do can have a range of different feelings about it and attitudes about it. And same with people who don't. I have many people who genuinely say, that's so interesting, that's so cool, I could never do that, right? But they're appreciative or interested that I do. But there is still this sense of like, that is across a line. For people who work, in mental health, like we all have our specializations, we all have the things we like, don't like, comfortable with, like that's fine. Nobody should have to, but it still isn't quite, I think, at that level of it feeling like a continuum. It still feels like there's a kind of hard line, and that's a different kind of thing that you do, right? And we use other language in the mental health field that I think can often be really problematic. We talk about things like high versus low risk, high versus low functioning, these ways of splitting people that becomes this kind of code that is often really reductive, right? And what it's like to actually work with those people, right? I work with people that are generally labeled as high risk. I generally don't find that to be my experience. I think that is one of the ways that we often label people, maybe especially people with BPD, based on this assumption of what they're going to do behaviorally. Is what it is that they're subjectively experiencing and suffering with and want to work on.
Yeah, I love your point in the book that medicine itself splits. And people with BPD get caught in this really damning binary of healthy, curable, or even curable, incurable, someone who's trying to get better versus someone who is treatment resistant. Those kind of labels I think are so bad too.
Absolutely.
But your encounter with Anna in the book is really respectful. I feel like there's a real sense where you're trying to let her voice come through. And I also got a strong sense that you were letting that encounter teach you things and challenge your own assumptions, which must be so important, but I'm sure not everyone does it. I just think of it too and how teaching changes my own ways of thinking. How would you say that your encounter with Anna changed you as a therapist?
Yeah, I mean, I completely agree with you about this idea of even when we're in positions of authority as a therapist or as a teacher, right, that there is this ongoing learning process. I find that also in my teaching role as well, that I learn so much from my students, but also about myself as a teacher by having to try to figure out how to actually be an effective, helpful resource. And so the same goes for working in therapy. And I think that individual patients like Anna and others that I write about in the book bring their own unique aspects, right? And I think that can be hard to summarize, I think, but also one thing that stands out when you work with people who are maybe fall within some kind of category diagnostically is you see both the commonalities and also all the great diversity. And that's how it makes it very apparent how much our current system of labeling is inadequate. Somehow it often misses a lot of things they seem to have in common, and then
Hmm.
overemphasize things that they actually don't and don't need to have in common to be their own person and to have the strengths and struggles that they have. And then another big part of the learning process was also I started work with Anna and a few of the other patients that I write about in the book in the early days of my private practice, which is this major
Hmm.
shift from being a doctor within some kind of institutional setting to being sort of
Right.
on my own, just me and the other person. And I think that was just for me, this major psychological head shift
Hmm.
that helped me see the more full autonomous nature of the people I was working with, right? When you're in a
Hmm.
hospital, can be so easy to silo people as
Right.
patients in a certain kind of pejorative sense. Whereas if it's just me in my office and them out there living their life, right, you have
Right.
to reconceptualize maybe what boundaries look like and what respecting
Yeah.
someone's autonomy looks like. And that forced a certain reassessment of what I'd been taught in some ways.
It's really interesting. Can you name something that people with BPD often have in common, but that is not alluded to at all in the DSM?
Something that I emphasize a lot in the book that since the book has come out and some people have had a chance to read it, it stood out as, I think, a word that has resonated with people that they hadn't previously encountered, which is this idea of confusion,
Hmm.
right? That I think a lot of people who are suffering from what we might call BPD have, without quite understanding it or knowing what to call it, have experienced sort of profound states of confusion for much of
Right.
and it can be captured by other terms, especially some that have become more popular and common in recent years, like gaslighting and sort of this idea of like
Right.
reality being in question and out there, but there's a subjective state, right, of really feeling like you're not entirely sure either what is real or what is coming from you versus from another person.
Right.
And though the DSM uses some terms like, identity diffusion and that
Right.
are jargony, it's not really quite the same idea. And there are even people who I meet who, I think in a lot of ways I would say have a pretty strong sense of who they are when they come to see me. Still, there is this core sense of there's something that they're very confused about
Yes.
that drives a lot of their suffering.
That struck me too, because I would say that for me, I met most of the criteria quite snugly with the criteria we have now in the latest edition, at least. But I never suffered as much from that lack of identity because I had certain things that had been common from the time I had memories. I wanted to be a writer. I loved books. I wanted a PhD because my mom had one or she was getting one at the time. And so having those
Mm.
goalposts to follow helped. But like you said, there was profound confusion. So that's an interesting way to formulate it. And I think that was one reason I really liked school because in school I could think about things and things could achieve some clarity with critical thinking and study and research, but there was just a lack of that clarity in my mind. So I'm glad it's striking a chord with people. So maybe we'll have more conversations about that, what that confusion is related to BPD and how do we help people with that. Another thing that was really interesting in your book was that you studied playwriting when you were at New York University, I think.
Yeah, that's right.
And you said some people were surprised when you seemed to switch tracks and go to the new school to study psychology. And you said that they are both about storytelling or helping other people to tell their stories. So I'm just wondering how that background as a playwright and clearly as a gifted, very lucid writer, how does that affect your sessions with patients, or does literature or that sense of stories really come out in any explicit way?
Maybe I would say it has sort of two influences. Yeah. So one is just on a very kind of core structural level, right? I've always been very
Mm.
interested in narrative, and
Right,
psychotherapy in some ways is more about not just constructing, but also deconstructing narratives,
right.
right? The stories we tell ourselves and being skeptical of them and considering where they come from and how much they actually are accurate or helpful anymore. And
Hmm.
learning how we can be flexible with telling and retelling our stories and trying not to get locked into a single story.
Right.
And so that, having a background in sort of story theory, right, is actually
Yeah.
quite helpful
Yeah.
because a lot of what you learn when you study that kind of writing in like a formal setting is, all of the patterns that have existed across the history of literature and the themes that reemerge,
Hmm.
ways that people structure things that resonate with human beings, right? That
Right.
there are these sort of known entities, ways that we try to organize the complexity of life and how that can be both really helpful, but also it means that we're cutting some stuff out, right?
Right.
And that can be said of my writing as well, right? I'm telling a particular story here, and there's things I had to cherry pick and things that I had to leave out. And then on the other hand, just more kind of in terms of it being maybe a less conventional background for someone who then becomes a psychologist, I think it can be really helpful. Just in general, I think, and I talk to my students a lot about how helpful it is to have various interests and backgrounds when you're working in mental
Mm,
health. It
yeah.
was, I write a bit about, I don't know if I talk specifically about this in the book, but I say at one point, one of Sigmund Freud's really radical, innovative ideas was this notion that you don't necessarily have to be a doctor to be a psychoanalyst. You just have to go through analysis, right? You have to
Mm,
understand yourself through this
right.
process. And then you can potentially pay that forward and become part of sort of the intellectual group of people who are practicing. And one of the things that he and his daughter Anna really advocated for was being like a well-rounded person, right? That it was you
Mm,
should read history and know about science, right? And I agree because oftentimes patients will bring in books they're reading, films they've seen,
right.
and being interested in that and open to that, right? Having maybe my own associations and metaphors or analogies that come to mind that aren't
Right.
just totally bound by a very linear education in one
Right.
discipline. I think can be really helpful. It can help patients see that therapy can be a more fully three-dimensional space.
Yeah, as a big fan of Miyazaki, I also liked that you presumably renamed one of the patients in your book as
That's right.
Haku from Spirited Away. So
Yeah.
since I knew you were using pseudonyms. And speaking of stories, you brought up Freud. I've always really enjoyed reading his case studies, even when some of his conclusions are a bit batty. I think he's a good storyteller. And I think there's one point somewhere in his papers, he says something like, it surprises me that I basically turned out to be a teller of short stories. So when we think of a case study of a patient in literature, we tend to think of the Freudian case study. I'm wondering, did you have any model for the form of your narrative about Anna in the book? Did you think about the Freudian case study structure, or were you thinking of something else or aiming for something else with that?
Yeah, I mean, and you're absolutely right. Freud is a great writer.
Yeah.
It's usually the comment I get first from students when they read him for the first time, is they were expecting something really dry and
Yeah, no.
inaccessible. And I mean, it was part of the power of his message was how eloquent he wasn't delivering it. And at the same time, right, he advanced a model of the case study that was then very influential and that he did not invent, that was, stemming off of medical writing preceding him, but that, had a very clear power differential in this of
Right.
the objective doctor putting a patient under the microscope. So one thing that I was really trying to do with this book, the extent to which I succeeded, I had to leave up to the people who were reading it, was
Yeah.
to not exclude myself from
Mhm.
analysis and to try to capture, as I walk through my experiences as a therapist, the associations I was experiencing, the anxieties I had, conversations I was having in my life outside of the consulting room, to try to capture some notion of what is sometimes called in contemporary psychoanalysis, the idea of a two-person psychology, right? That therapy
Mm,
is not one objective mind analyzing a
right.
subjective mind. It's two people figuring something out together.
Yeah, that inner subjectivity is so important.
Exactly. Yes.
Yeah.
And so I was hoping to convey the importance of that in some way
Yeah.
by having this be a recognizable case study, but maybe some sort of different from what you're used to encountering.
Right. Yeah. Well, I definitely think that comes across even from the very beginning, where the first day you meet Anna, you had found a dead bird outside your door, and you talk about the different associations you have with that. Even, in that first session with her, I had never really seen anything like that in a case study. Like you say, like the authority figure, the person in the doctor role kind of opening up about what they were, the associations and the story that they were making about this exchange. So that was really interesting. And later on, things you say, like something really striking and really perceptive from your wife, that she occasionally feels some sense of being left out because you have such intense relationships with your patients, and you had been concerned that what might bother her was when there was any transference and a patient develops feelings for you, or, at least briefly, but it was more that sense of the intensity of the relationship. And I thought that was really remarkable and interesting. For people like me who've been in therapy a lot, we might not often think about the impact or the effect on the clinician helping us. So it's really interesting. And I'm sure that's not easy to share all those things.
Yeah, I mean, I think it is therapy is such a complicated, and I mean, obviously, I think like endlessly fascinating
Yeah.
process. And yeah, the extent to which two people come together and the intensity of it, but also at different points, both therapist and patient might have their own reasons for acknowledging or not acknowledging that intensity.
Mm-hmm.
Because I can really obviously only write from my perspective, trying to capture in some way that my experience working with patients necessarily sometimes involves that I'm working through things too, not necessarily in the exact same way as my patients, not with the same things, but that again, towards this idea of trying to promote that we're all on some kind of shared continuum, that it's different, but it's not like qualitatively different, right?
Right.
There's something we all have in common as we try to work through these
Yeah.
basic ideas of like how to live and how to be in relationships with others and what intimacy and love and attachment and separation mean and all
Right.
of that.
Yeah. How to feel things, what to be afraid of. Absolutely. And that leads up pretty nicely to my final question. I want to quote a couple of things you said in the book. You write at one point, well, you say several times the phrase, "we always add, never subtract," which I think is great. It kind of builds the repetition, that message. And this time you write, "We always add, never subtract, all the way down to the psychotic core. We can only be ourselves, and the things that happen to us that make us ill also have the potential to serve as sources of empathy and ideas that challenge a toxic status quo," which I definitely agree with. And I know I've talked to other people with lived experience of BPD who I believe would agree with that as well. And then you also write that psychoanalyst Otto Kernberg distinguished between pathological narcissism and normal narcissism. And of course, narcissism being another personality disorder, but has that distinction. And so you ask, and I thought this was a great question, had no one over all these thousands of years suggested that there might be a normal borderline? Do you think that the fields of psychology and psychoanalysis, or just medicine in general, are getting any closer to embracing this idea of a normal borderline? And if not, why not?
Yeah, I mean, I think that nothing moves in a unified direction, right? So
Right.
there are some trends maybe that are continuing to reify the stigma that exists.
Right.
But I also think there are reasons to be hopeful that the way we think about BPD in particular and sort of personality disorder in general is
Mm-hmm.
trending towards something that's closer to human experience and
Mm-hmm.
less artificial and stigmatizing. There's a lot of growing interest initially in more academic psychology and moving towards clinical psychology in looking at personality as intersecting dimensions.
Yeah, I talked to another therapist who mentioned that as well. So saying maybe everyone has components of these different personality disorders, as we call them. It's a question of degree, but usually it's not just one. It's, I'm a 2 with NPD or a 3 with BPD.
But the idea of there being these, traits and qualities that people vary on it, and that,
Right.
is my experience as well. I mean, speaking of, when you're asking for like, what did I learn from working with borderline patients? It's also worth noting what I learned from working with patients who are not labeled as borderline, who often have
Right.
much in common and struggling with the same,
Yes.
relationship issues, fears of abandonment that are not, again,
Mhm.
qualitatively different, but
Right.
that we organize it a little bit differently. They have different lived experience.
Yeah.
And so the idea of moving towards mapping our concept of psychology and personality onto sliders that can move up and down.
Right.
I have a colleague at Fordham University where I'm a professor who specializes in sort of dimensional models of personality. A
Mhm.
former mentee of mine who's just started getting her PhD in Brazil, where she's from, emailed me not long ago to say that she was taking a class on dimensional models of personality, which like
Right.
was not remotely available when I was in graduate school. Like
Right.
it is
Yeah.
moving in that
Yeah.
direction. I was just at an event this past weekend where someone kind of offhandedly mentioned he works in sort of substance abuse space, so it's a different world, but was talking about
Right.
movements that exist around exploring whether people can be credentialed for lived experience, right? Sort of in thinking about a peer advocacy and peer therapy
Right.
model. Is it
Yeah.
possible to actually give people credit within a more formal institutional setting for the
Hmm.
that have lived through and the value that that adds and their ability to help other people? These are all relatively new ideas, especially that
Yeah.
they're discussed in somewhat mainstream, university
Yeah.
settings. So that all I think is worth feeling somewhat optimistic about.
Yeah, it's really interesting. I've heard, I have a friend who's a social worker that, especially for people treating substance disorder, some places will only hire people who do have lived experience. So that's interesting. The idea of credentials for lived experience is pretty fascinating. Is there any final thing that you would like to say about the book or about anything else?
I don't think so. I thank you so much for having me. Part of why I wrote the book was hoping to kind of join a discourse around
Hmm. Yeah.
this diagnosis and related issues. And I feel very privileged to be part of a conversation like this and this project of this podcast that you're doing, which is so much aligned with, I think, the kind of ideas that have been lacking for so long, are really sort of gaining some traction, which is so exciting to see.
I was really happy to read the history part of your book because, especially from the hysteria parts on, you were kind of confirming a lot of things that I was thinking. But of course, I don't have the training. My PhD's in comparative literature, so it's very different. So that was interesting. But I loved the scenes with Anna as well. And I think that for people with BPD who may have had some negative experiences in the past with clinicians and or hospitalizations, and that does unfortunately seem to be a lot of us, it's really beautiful to have an example of a caring, respectful, thoughtful, ongoing relationship between a therapist and a patient. So if anyone is interested in seeing what that might look like if they've only had negative experiences, that's something that your book can really offer. I mean, it offers numerous things, but I think that portrait of a healing and supportive relationship is such a beautiful and unique aspect of Borderline, the biography of a personality disorder. So thank you so much for that.
Thank you. Yeah, I think that's a great note to end on. It's just this idea that like treatment is not a one size fits all, and that if someone has had bad experiences, that does not mean that they did it wrong or they
Right.
are cannot be helped, right? It
Yeah.
may be that they did not find a good fit.
Right. Exactly. Yeah. Well, thank you so much, Alex. Yeah.
Thank you.